Hello everyone. Why do some spinal anesthesias or neuraxial block feel effortless while some become a nightmare? Where does the difference lies? The difference lies in approach. I'll share with you the exact checklist I use before every neuraxial block so that every difficult case can be managed. A structured assessment leads to a better success rate. In this class, we will discuss indications and contraindications of spinal anesthesia or neuraxial blockade, dermatomal level requirements of some basic surgeries, factors affecting block height. Factors affecting block height is an important topic, and understanding this topic will help you achieve desired block height in a difficult case as well for a desired duration as well. And finally, I will share with you the exact checklist. Indications. Most important point for indications is site of surgery. So, surgery of lower abdomen, surgery of perineum, or surgery of lower extremities. In these cases, we can use neuraxial blockade, spinal or epidural. It becomes more important if the patient has difficult airway, decreased mouth opening, post-commando patient, or patient has a respiratory issue such as severe asthma or COPD. Giving general anesthesia in patients with respiratory diseases might land them up in post-op mechanical ventilation. So, regional anesthesia or spinal anesthesia helps preventing mechanical ventilation in patients with poor chest conditions. Now, some specific surgeries such as cesarean section and TURP. So, in cesarean section, giving regional anesthesia or neuraxial blockade helps baby to or fetus to avoid drug transmission and respiratory depression or other complications. And in TURP, giving spinal anesthesia helps identification of TURP syndrome. So, what we have to see is, whenever we consider a neuraxial blockade, we have to see the nature and duration of surgery. So, we have to see the nature and duration of surgery. One point, we have to see the patient's comorbidities. Then we have to see the ease of spinal insertion. Ease of spinal insertion. Ease of spinal insertion means, is the patient able to sit? Is the patient able to give position? And the spine anatomy is fine. We can able to insert needle. We have to also see that the patient is willing to remain conscious during the surgery. And we have to see the benefits versus risk of giving general anesthesia or spinal or regional anesthesia to the patient. So, after this, neuraxial blockade can be used to give anesthesia or analgesia. So, in anesthesia, we can give spinal anesthesia, subarachnoid block. We can give continuous spinal anesthesia via intrathecal spinal catheter. Then we can give segmental spinal used in lap chole in patients with poor chest conditions. In analgesia, we can use combined spinal epidural. Then we can give epidural only. Then we can use neuraxial blockade for acute and chronic pain management, and then we can give additives to increase the duration of action of local anesthetic. After indications, we will study the contraindications. The absolute contraindication is patient refusal. Patient is denying. Patient does not want to remain conscious during the surgery. This is the absolute contraindication. Localized sepsis or systemic infection is also a contraindication. Allergy to the drugs planned for administration, the local anesthetic allergy is also a contraindication for giving neuraxial blockade. Raised ICP may lead to herniation, so signs of raised ICP should be seen in a patient with head injury, and regional anesthesia should be avoided, or in any patient like tumor where the signs and symptoms of raised ICP are seen, we should avoid giving neuraxial blockade. Talking about relative contraindications, we will see system wise. Neurologic, if the patient has any myelopathy, patient has any peripheral neuropathy, so a pre-existing neurological deficit might get worsened. So we have to avoid giving neuraxial blockade to these patients. Now, chronic low back pain is not a contraindication, but we have to avoid it. Avoid giving neuraxial blockade to these patients. If the patient has spinal stenosis, it can lead to neurologic complications, so we have to avoid. History of spine surgery. If the patient has history of spine surgery, we have to see the patient's anatomy post surgery. There will be presence of scar. There might be presence of adhesions. Then there can be presence of implant of previous surgery or bone graft. So we have to take a history of spine surgery, and these conditions may make it difficult for needle insertion and unpredictable drug spread. So we have to ask the patient that patient had any spine surgery or not. Patients with multiple sclerosis is a demyelinating disease. The myelin sheath gets removed. So what happens is the patient becomes highly sensitive. There is increased sensitivity to the drug, as well as the duration of the drug increases. So better to avoid, and if necessary, we have to decrease the dosage. Patients with spina bifida, they can have a wide spectrum of congenital spinal cord malformations, so it is better to avoid giving neuraxial blockade in these patients. Talking about cardiac system, if the patient has aortic stenosis or fixed cardiac output state, what happens is after giving neuraxial blockade, there is decrease in systemic vascular resistance. Decrease in systemic vascular resistance leads to decrease in MAP and might lead to decrease in coronary perfusion. As the patient has fixed cardiac output state, we have to be very cautious, and what affects is the decision depends on the left ventricular function. So what matters is left ventricular function, and we have to prefer a intrathecal catheter. We have to prefer an intrathecal catheter so that doses can be given in aliquots, and we have a better control. We have a better control over hemodynamics of the patient. Giving drug in small doses will help us attain better hemodynamic control on the patient. So in fixed cardiac output states, it is better to use intrathecal catheter if the neuraxial blockade is must. Then hypovolemia. So after giving subarachnoid block, the systemic effects of subarachnoid block on cardiovascular system are such that there is decrease in preload, decrease in afterload, decrease in cardiac output. So if the patient is hypovolemic, these effects become exaggerated and we have to correct hypovolemia before giving neuraxial blockade to such patients. Talking about hematologic conditions, if the patient is on any thromboprophylaxis or patient is on any blood thinner, then we have to follow ASRA guidelines to discontinue the drug before giving neuraxial blockade. I will just discuss few of the drugs. So, direct oral anticoagulant drugs such as apixaban, edoxaban, rivaroxaban, and dabigatran. Talking about their high doses, they have to be stopped 72 hours prior to surgery. Then unfractionated heparin, if the dose is low, then 4 to 6 hours, and if the high dose is there, then 12 hours, and low molecular weight high dose is 24 hours. Warfarin, we have to stop 5 days prior to surgery. Clopidogrel 5 to 7 days prior to surgery. Ticagrelor 5 days prior to surgery. Then prasugrel 7 to 10 days prior to surgery. If we talk about platelet GP2B3A inhibitors, then abciximab is 24 to 48 hours prior to surgery. Eptifibatide is 4 to 8 hours. Tirofiban is 4 to 8 hours prior to giving neuraxial blockade, and cilostazol is 2 days prior to giving neuraxial blockade. If the patient has inherited coagulopathy, so inherited coagulopathy, von Willebrand disease, hemophilia, and idiopathic thrombocytopenic purpura. Platelet count more than 80,000, we usually give spinal anesthesia to patients who have more than 80,000 platelet count with single shot spinal by an experienced anesthetist. If the platelet counts are low, then we have to increase the platelet count. Presence of an infection is a relative contraindication. Patient might be febrile, patient might have systemic infection, and we have to see whether the antibiotic has started or not started, what was the TLC count, and has the TLC count started reducing. So depending upon the whole scenario, then we can choose to decide whether to give a neuraxial blockade or not. If the patient has any skin conditions such as psoriasis, or there is a tattoo on the back or at the site of insertion, so we have to avoid giving subarachnoid block at the pigmented site. Site of insertion should not be the pigmented site of the tattoo, as it might take the pigmented segment into the intrathecal space. So this was indications and contraindications of neuraxial blockade. Talking about dermatomal level requirement for some basic surgeries. So this is from Miller's. Upper abdomen surgery level required is T4, cesarean section T4, TURP T10, hip surgery T10, then foot and ankle surgery L2. So for any surgery, you have to ask the surgeon what is the incision from where to where. We have to ask the surgeon skin incision lies from where to where. Suppose T6 to T10 or T4 to T10. So you have to block accordingly, and then you have to see the visceral organs involvement. Is there any stretch, or is there any graft to be taken during this surgery? So you have to see the whole picture. What are they going to do, and from where to where they are going to extend their incision. Now coming to the most important topic of this class, this is factors affecting block height. So factors affecting block height, we need to understand them because they will help us to attain a desired block height for desired duration. So there are three most important factors. One is drug, second is patient factors, and third is procedure factors. So in drug, the more important factors are dose of the drug we are giving and baricity of the drug we are choosing. In the patient, the more important factors are what is the CSF volume of the patient, what is the age of the patient, and is the patient pregnant or not. In procedure, the more important factor is patient position and if we are using combined spinal epidural. The less important factors in drug is volume of the drug, temperature of the drug, concentration of the drug, and viscosity of the drug. Patient less important factors which less affect the block spread is weight of the patient, height of the patient, spine anatomy, and intra-abdominal pressure. And procedure factors which are less important, level of injection we are giving, fluid currents, needle orifice direction, and needle type. So we will be discussing each of them. Talking about drug, what is baricity? So baricity is a comparison of density of local anesthetic and CSF. So what is the formula of baricity? Density of local anesthetic divided by density of CSF. Density of local anesthetic divided by density of CSF. And what is density? Density is mass per unit volume at a specific temperature. So baricity is measured at a specific temperature. Density of CSF is 1.00059 gram per ml. So, if a local anesthetic has the same density as CSF approximately, then it is isobaric. If the local anesthetic density is less than this number, then this is hypobaric drug, and if it is more, then it is hyperbaric drug. And what is specific gravity? Specific gravity is density of a substance upon density of water, whereas baricity is density of local anesthetic upon density of CSF. So, this is the curvature of the spine. If we are making the patient lie supine immediately after giving drug, so what happens? How is the spread happening? So what happens is in hyperbaric drug gets collected in the most dependent part of the spine. As the patient lies, the sacral and the thoracolumbar, lower thoracic and lumbar region becomes, this is the lower thoracic region, which becomes most dependent part of the spine, and the drug spreads along this part. It follows the gravity. Opposite happens in if we use hypobaric drug. Hypobaric drug goes against the gravity. So it gets collected at the sites which are most non-dependent. And isobaric drug spread is simple. It gets spread at the site of injection. So it remains where it is injected. Very simple. What is helpful? Hyperbaric drugs have most predictable spread. So it helps us get the desired effect. We can change the position of the patient as per our convenience and get the desired block height. So this is about supine. If we talk about sitting, sitting is usually used for saddle blocks, and in saddle blocks sacral region need to be anesthetized. So we make the patient sit for around 10 minutes, and the most dependent part of the spine, that is the sacral region, gets blocked. If we talk about lateral position, there is a difference in male and female patients we will discuss ahead. So drug dose is volume of the drug into concentration of the drug. Let me give you an example. Suppose I am using 2 ml of 0.5% bupivacaine. So heavy. So what is the volume? Volume is 2 ml. What is the concentration? Concentration is 5 mg per ml. So what is the dose? 10 milligram. So now you understand, if I use 2 ml of 0.75% ropivacaine heavy, then the dose becomes 2 into 2 ml into 7.5 milligram per ml. So this becomes 15 milligram. Dose is volume into concentration. Dose is the most important factor among dose, volume and concentration. So dose is the most important factor among dose, volume and concentration for spread and duration of block. If we talk about only spread and duration of block height, or we talk about block height and spread, then dose is the most important factor for isobaric drug and for hypobaric drug. Whereas if we talk about a hyperbaric drug, for a hyperbaric drug, the most important or the most influenced factor is baricity. So for spread and block height, choice of local anesthetic has no effect on spread and block height. Adding an additive has no effect on spread and block height, except there is an exception. There is an exception of opioids. Opioids affect spread and block height. So this was about drug. Few things I would like to add here is warming a local anesthetic. Warming a local anesthetic decreases baricity. You must have seen some of the technicians doing like this to the ampule. Warming a local anesthetic leads to decrease in baricity. And one more thing I would like to add, if we compare a less hyperbaric drug with a more hyperbaric drug, so what will be the spread? So a more hyperbaric drug will have more predictable spread as compared to a less hyperbaric drug. And I would like to add one point about hypobaric drug. Hypobaric drug, as it follows against the gravity, so it is used in rectal surgeries, in surgeries with perineum, where the patient lies in jackknife position. So after giving spinal anesthesia, the drug goes to the most non-dependent part of the spine and blocks the sacral portion of the spine. Then in patients who have fracture, unilateral fracture, suppose a patient has a unilateral fracture or not able to sit or not able to lie, and suppose this is the patient and this is the patient and this is the fracture site. So giving an isobaric drug will help attain a unilateral block in the site of fracture. Now we will discuss the patient factors. So CSF volume. CSF volume and age and pregnancy are important factors. CSF volume affects peak block height and regression of the block as well. So volume, CSF volume is inversely related to spread. More the CSF volume, less will be the spread of the drug. If we talk about pediatric and adult cases, so in pediatric cases, approx CSF volume is 50 ml, whereas if we talk about volume in ml per kg, it is 11 to 15 ml per kg, which is much higher as compared to adults, which is 2 to 4 ml per kg. As the volume per kg is much higher, the circulation time in pediatrics, CSF circulation time in pediatrics is much higher, and that is why as the drug gets circulated very early, the drug gets absorbed very early, eliminated very early, so we have to give a higher dose, drug dose in pediatric patient, and as the circulation time is very high, the regression of the block is very early in pediatric patients. So this was about pediatrics. Increased circulation time leads to early regression of block, and we need to give more drug as the circulation is more. Talking about pregnant patients has increased intra-abdominal pressure leading to decreased CSF volume and leads to increased block height. So we have to give a little less volume of drug or less drug so that the spread is not high, or patient does not get a high spinal. Same with obese patient. Obese patient has increased intra-abdominal pressure, due to which the spread, the CSF volume decreases and the spread becomes high. So we have to take caution in these patients. Then circulation is more in pediatrics, as I have discussed. If we talk about age, increase in block height is seen in elderly patients. Elderly patients have faster onset, increased duration of action, and increased block height. Why is that so? This is because they have less CSF volume and the sensitivity to local anesthetic increases as age increases. So we have to decrease the drug dosage in patients who are elderly. If we talk about height, the local anesthetic spread is only related to vertebral column length. It is not related to the overall height of the patient. It only relates to the vertebral column length of the patient. This is the position of the patient in lateral, and this is the perfect position. Shoulder and hips are vertical to the patient and knees drawn up to the chest with a pillow, and the spine open up with the intervertebral spaces become opened up. So if we compare a male versus female, due to broad shoulders of the male, there is a slight head up position in males, whereas due to broad hips of the females, there is slight head low in females. So we have to keep this in mind while giving block. Talking about CSF density does not have much effect on the block height, but just for the completion, women have less CSF density as compared to men, and premenopausal women have less CSF density as compared to postmenopausal, and pregnant females have less CSF density as compared to non-pregnant females. Talking about BMI and obesity, BMI or obesity is more important. BMI of the patient is more important than weight of the patient. So weight has less influence on block height as compared to BMI. BMI has more influence on block height. We will discuss about scoliosis and kyphosis. So scoliosis is lateral deviation of the spine and kyphosis is anteroposterior deviation of the spine. So we will discuss in two terms, needle insertion and drug spread. Needle insertion and predictable drug spread. So these are the 2 points in which we will discuss scoliosis and kyphosis. Needle insertion is difficult in scoliosis, whereas easy in kyphosis. Drug spread is easy in scoliosis, whereas drug spread is difficult in kyphosis. These are the points for patient. A quick question for you. A morbid obese patient comes to you for a surgery with non-palpable landmarks. So what will be your priority? Choice of needle, positioning of the patient, or drug dosage? Comment below before I reveal. Coming to the procedure, patient position and epidural injection post-spinal, that is CSE, combined spinal epidural, are the important factors, and less important factors are level of injection, fluid currents, needle orifice direction, and needle type. So position should not affect the spread of isobaric drug. As we have already discussed, isobaric drug spread is simple. It spreads at the site of injection only. So position does not affect the spread of isobaric drug. Drug stops spreading after 20 to 25 minutes of injection. So the game is only for initial 10 to 20 minutes and the spread stops after that. So achieving a block height is during the early few minutes of the injection. We have to make the head down tilt. We will do it so that the drug ascends. Flexion of hips helps in straightening of the spine curvature. For saddle, we have to make the patient sit for 30 minutes. 30 minutes is written in Miller's. What we use in our hospital is 10 minutes and we achieve the effect in 10 minutes as well. Cuffing or straining has no effect on ascent of the drug. Talking about needle orientation. So directing our needle orifice to one side will have more unilateral effect as shown in this diagram. Ejection of the drug will be like this if unilateral or center like this. Injection rate, barbotage, cuffing and straining. Injection rate, barbotage, cuffing or straining does not have any effect on ascent of the drug. What is barbotage? Barbotage is aspirating of the CSF while giving drug. So no effect. Duration of the block depends on the dose of the drug we are using, type of local anesthetic we are using, and additives what we are using. Finally, the checklist. So what you have to see while you do a PAC for a patient. So you have to see the nature and duration of surgery. You have to see the patient comorbidities. And then you have to see the ease of spinal, whether the patient will be able to sit, whether the spine anatomy is visible or not. So a structured assessment has a better success rate. So what you will do is you will take a history of the patient and in history you will ask if there is any history of previous spine surgery, is patient is on any anticoagulants and when was the last dose taken, if the patient has any neurological disease or neurological symptom, is the patient pregnant or is there any signs and symptoms of infection. After history taking, you will see the examination. On examination, you will assess the BMI. You will see for spine deformity, positioning, will the patient be able to sit, and you will see the intervertebral space, are they palpable or not. So after all of this, after history taking and examination, you will discuss with the surgeon. You will ask for the duration of surgery, expected duration of surgery. You will assess the level of block required. After confirming these two, level of block and duration of surgery, you will decide the drug dosage and then you will proceed for neuraxial blockade or subarachnoid block. If this helped you, please hit that like button and share and subscribe. See you in the next one.